You can start.
شكرا دكتور بدر. السلام عليكم. I'm Hana, fellow F1 from National Guard Hospital. I'll talk only the highlights of the revision in PI-RADS, as Dr. Badr mentioned. But first, we'll start the cases. So this is the first case. What is your PI-RADS scoring for observation A and B?
بالنسبة للفلوس, this is part of your promotion exam. انتبهوا. هنا ما طلع البولينج. Can you try?
No.
Okay.
Okay. So this is our polling. Most of you agreed that it's A, normal, and the set B is PI-RADS 4 lesion. We'll see the final result at the end of presentation. So for case 2, what is your PI-RADS score for this lesion? Okay, I'm ending the polling. So most of you agreed that it's a PI-RADS 5 lesion. What is your PI-RADS score? Okay, I'm ending the polling. So most of you agreed that it's 39%, 91% agreed that it's a PI-RADS 5 lesion. So if you had history of a previous intravesicular PCG injection for a superficial bladder cancer 1 year back for the same lesion, what would be the most likely diagnosis? Okay, ending the polling. So majority was going with granulomatous prostatitis. Some was going with post-prostatitis changes. Few were going with prostate cancer. We'll see the answer later. What is your PI-RADS scoring for this lesion? Okay. Ending the poll. So majority was going with a PI-RADS 2 lesion with 38%. 31% was going with a PI-RADS 4 lesion. 29% was going with a PI-RADS 3 lesion. Okay. So case 5. Ending the polling. So as you can see, most of you were going with a PI-RADS 4 with 35%. A few was going with a PI-RADS 2, PI-RADS 1, and only 13% was going with a PI-RADS 3. Okay, now we'll start our talk. Prostate imaging reporting and data system was first created in 2012, and then the first revision was created in 2015. After that, they studied the variability of a positive predictive value of a PI-RADS for a prostate MR across 26 centers using the V2 version of 2015. They concluded that the positive predictive value of the prostate imaging and reporting data system was low with varied widely across centers. So it did not have that great of positive predictive value, especially for the transitional zone lesions. Now, there is a new update that was released in 2019, which I will be talking about the major changes, which talked about the anatomical sector map, image acquisition, interpretation criteria for T2 diffusion and perfusion. And I'll talk about the major PI-RADS scoring system that was changed upon the new revision. First, the anatomical sector map, they added 2 more sectors. They are the right and left posterior medial peripheral zone, as we can see here. So they have shortened the central zone, and they added 2 more peripheral zone, posterior medial peripheral zone. Now they became a total of 42 sectors. They emphasized on the central zone and the anterior fibromuscular stroma, as they had great pitfalls, and they might represent a mimicker for malignancy, as we will talk now. The central zone, as we know, it's normal tissue that surrounds the ejaculatory duct. Normally, it is bilateral, relatively symmetrical, dark on T2, with typical appearance on the coronal images of bunny ear or mustache, teardrop. It shows dark signal intensity on ADC with mild bright signal intensity on diffusion, and normally it does not have enhancement in the perfusion images. How to tell normal central zone from tumor invading central zone? Well, first is asymmetry. Usually central zone are symmetric. Sometimes they may appear as slightly asymmetric on the axial images due to underlying PPH nodule displacing one side. Always go back to the coronal images. It helps in the anatomy. It looks as teardrop or typical mustache or bunny ear appearance. Next, assess the focal early enhancement to the post-contrast images and assess the diffusion ADC map. Usually it shows symmetric mild diffusion restriction. Here we can see in the lower images, this is an example of a tumor involving the central zone. As we can see here, there is asymmetric dark signal intensity involving the left central zone and involving part of the posterior medial peripheral zone. Next, we will assess on the coronal images. Still, it looks asymmetric, discrete focal area of dark T2 signal intensity. If we assess the diffusion and ADC map, we can see that there is clear asymmetric discrete focal signal intensity on diffusion that is intensely bright with corresponding intensely dark ADC signal. So this is a worrisome lesion. We have to increase the likelihood of prostate cancer. Whether to use peripheral zone criteria or transitional zone criteria, usually central zone lesions are secondary invasion from a peripheral zone. So preferably to use a peripheral zone criteria for these lesions. As for the anterior fibromuscular stroma, it's a normal crescentic region anteriorly. Normally it is dark on T2, dark on ADC, and dark on diffusion, without focal enhancement in the early post-contrast images. When it's normally thinned and symmetric as this, it's very easy to know that this is anterior fibromuscular stroma. The pitfall comes when it's hypertrophied or asymmetrically thickened, which may fool you as a true lesion. If you see here in the axial T2, we can see that there is focal discrete abnormal signal intensity, dark, homogeneous, circumscribed. You might think that this is a lesion at first glance, but if you assess the diffusion, ADC, and perfusion images, it is dark on diffusion, dark on ADC, and no focal enhancement in the perfusion images. So this represents a hypertrophied or thickened anterior fibromuscular stroma. Unlike these images on the below row, we can see asymmetric dark signal intensity on the left anterior transitional zone and thickening of the left anterior fibromuscular stroma with corresponding significant diffusion restriction, focal area of intense bright diffusion, intense dark ADC. So this is a PI-RADS 4 lesion. For anterior fibromuscular stroma lesion, we can apply either peripheral zone or transitional zone criteria, depending on the epicenter of the lesion. For this lesion, we may think that it's predominantly a transitional zone involving the anterior fibromuscular stroma, so we can apply transitional zone criteria. Second thing that was emphasized or revised on the 2019 revision was image acquisition. For T2, previously there was no specification on the plane or the measurement technique, but now they made it clear that we needed an axial plane, T2, plus at least one additional plane, sagittal or coronal, and the measurement has to be taken transverse diameter from the axial T2, the longitudinal diameter and AP diameter from the sagittal images. Why specify the technique of measurement and the plane? They wanted to reduce the inter-observer discrepancy or variety for the prostate volume and subsequently the PSA density. So they wanted all of us to talk the same language, to measure the prostate in the same technique, to have a uniform measurement technique for prostate volume and subsequently the PSA density. As for diffusion, previously there were no mandatory requirements. A high p-value was preferable, but now it is mandatory to have a high p-value with a cutoff of 400 or more, 1400 or more, sorry. They found that having a high p-value increased the detection rate of clinically significant prostate cancer, especially with lesions near the anterior fibromuscular stroma subcapsular lesions, and small lesions at the apex of the prostate gland. For the perfusion, they have increased the temporal resolution time to be less than 15 seconds. Previously was less than 10 seconds. Because they didn't want to compromise the spatial resolution and image quality. And they asked for, they emphasized on having a 3D T1 gradient images over 2D. Third thing that was revised was the image interpretation. This table summarized the major scoring difference for score 1 and 2 for a T2 lesion in the transitional zone. Previously, we needed to have a normal transitional zone to call it score 1 on the T2, but now they have extended the definition to include the typical PPH nodule, which is defined as completely encapsulated nodule, as you can see here, completely encapsulated nodule. This nodule, you don't have to report it, it's considered as a PI-RADS score 1. For the score 2, they gave new definitions for PPH nodule, which is atypical PPH nodule, defined as either homogeneously circumscribed nodule or mostly encapsulated nodule as this nodule, or having a homogeneous, mildly hypointense signal in between the nodules, as we can see here. This is just a diagram to illustrate the typical and atypical nodule. Completely encapsulated nodule is scored as 1. Atypical nodule, either homogeneous circumscribed nodule without a capsule or mostly encapsulated circumscribed nodule, still considered as atypical nodule and scored as 2. Having oval shape or cystic changes within the nodule is very acceptable. For the diffusion lesions for both transitional zone and peripheral zone, the main changes were on score 2 and 3. For score 2, they emphasized on the morphology of the lesions, having linear wedge shape hypointensity on ADC, as we can see here, or linear wedge shape bright signal intensity on diffusion would be scored as a PI-RADS 2, even if it's intensely dark. Here we can see one example. I got this image and interpretation from Mayo Clinic slides. We can see here a right peripheral zone linear lesion that showed dark signal intensity on T2. Here it is on the sagittal. We can see on the diffusion and ADC, it is intensely bright on diffusion, slightly or very mild dark on ADC map. Previously, we would score this lesion as a PI-RADS 3 lesion, but with the revised PI-RADS system, we would downgrade the lesion to be a PI-RADS 2. Fusion biopsy of this lesion showed PIN, which is prostate intraepithelial neoplasia, a precursor for prostate cancer, low and high grade. Only the high grade PIN would require follow-up at 1 year. So by downgrading this lesion, we are reducing the number of unnecessary biopsy and still not miss a high grade or a clinically significant prostate cancer. For score 3, they have extended the definition of PI-RADS 3 lesion on diffusion to include lesions with markedly dark signal intensity on ADC or markedly bright signal intensity on diffusion, but not both at the same time. So you can have a lesion that is very dark on ADC, slightly bright on diffusion, or vice versa, and still call it a PI-RADS 3 lesion. This is the major change in the new PI-RADS system. As for the perfusion, they have adjusted the definition of negative score for perfusion to be no early or contemporaneous enhancement or presence of diffuse multifocal enhancement that does not correspond to focal findings on T2 and or diffusion, or having focal enhancement that corresponds to a PPH nodule, including the extruded PPH nodule that is seen in the peripheral zone. So if you have an extruded PPH nodule within the peripheral zone and it's enhancing, it's still scored as negative. If you have diffuse multifocal enhancement that does not have a corresponding abnormality on diffusion or T2, it's still considered negative. This is the major scoring difference in the revised PI-RADS system. Mainly, it affected the transitional zone lesion of a score of 2. Previously, if we have a PI-RADS score of 2 on T2 for the transitional zone, we would just keep it a PI-RADS 2 regardless the diffusion. However, in the revised PI-RADS system, if you have a PI-RADS score 2 lesion from the T2 weighted images, which is the atypical nodule, either circumscribed, homogeneous, or mostly circumscribed, mostly encapsulated circumscribed, then we need to go and assess the diffusion. If the diffusion and ADC map had a score of 3 or less, then the lesions, the final PI-RADS scoring would be a PI-RADS 2. But if the lesion had a diffusion score of 4 or 5, then we need to upgrade the final PI-RADS score to a PI-RADS 3. Here's just another example. We can see here a nodule in the left transitional zone. It is mostly encapsulated. Here we lose the capsule. So it's a score of 2 from the T2 weighted images. Next, we need to assess the diffusion and ADC map. We can see here it is markedly bright on diffusion, dark on ADC map. So it's a score of 4 and it's less than 1.5 centimeters. So we would score it as a score of 4 in the diffusion. Previously, we would score this lesion as a PI-RADS 2. But in the updated version, we would upgrade the lesion for a PI-RADS 3 lesion. This is just one study. Compared the PI-RADS version 2.1 versus the previous version 2 regarding the inter-reader variability and diagnostic accuracy of transitional zone prostate cancer only. They have included a total of 85 patients who underwent both biopsy and MRI within 6 months of each other. The reader was one junior radiologist with only 1 year experience in prostate MR and one senior radiologist who had a total of 6-year experience in prostate MRI. Here we can see the table. Reader 2 is the senior radiologist with 6 years experience. This table, Reader 1 is the junior radiologist with only 1 year experience. We can see here the columns. The first column represent the V2 version, the previous version, and the shaded column represent the updated version. The gray area represent the clinically significant cancer that was scored by the radiologist, and the shaded gray area represent the clinically significant prostate cancer in the updated version. So if we are comparing, we can see here that the experienced radiologist or the senior radiologist had much less number of clinically significant prostate cancer that was scored as a PI-RADS 2 compared to the previous version. And much higher number of clinically significant prostate cancer was scored as PI-RADS 3 and 4 in the updated version compared to the previous version. As for the junior radiologist, he didn't have much difference in the PI-RADS 2 scoring, but he had increased number of cases that was called as, that was a clinically significant prostate cancer and scored as a PI-RADS 3. The reason behind this could be related to lack of experience, as the reader one had only a 1 year experience and they didn't study his assessment after a proper clinical training in prostate MR. And here we can see just the area under the curve. We can see the dotted green line represent the senior radiologist using the updated version compared to the orange dotted line using the previous version, which showed significant increase in the accuracy. This is just one example from their cases. We can see here a transitional zone nodule. They gave it a score of T2 score of 3 in the previous version, diffusion score of 3, so the total PI-RADS score was 3. But using the updated version, we can see that the lesion is almost encapsulated, where we lose the capsule posteriorly. Then we need to go to the diffusion. We can see that, so it's considered an atypical nodule, score of 2. We will go to the ADC and diffusion. There is only mild diffusion restriction, so we would score it as a diffusion score of 3. The final PI-RADS score would be a PI-RADS 2. Clinically significant prostate cancer is unlikely. Indeed, biopsy showed a non-cancerous lesion on the PPH findings. So now, after we went over the major changes in the revised PI-RADS scoring system, we'll go back to our cases. This case, most of you got it right. Just let me go back to the scoring system. So this is the anterior fibromuscular stroma. Most of you got it right. 60% actually of the attendee got this answer right. And the PI-RADS for this lesion, we can see here the lesion is intensely bright on diffusion, intensely dark on ADC, with early focal enhancement and corresponding discrete focal abnormality on T2. So the PI-RADS scoring would be a 4. 60% of you got it right. 36% of you went with the PI-RADS 3 and PI-RADS 4. They were thinking that this is a lesion, but it's not a true lesion as we described. This is normal anterior fibromuscular stroma that is just mildly thickened. This is the gross image. We can see this is clear, normal anterior fibromuscular stroma. And this turned out to be Gleason 4+3 lesion, going with our PI-RADS scoring. For this case, if we will go with it, if we can see the T2, it's a transitional zone lesion. It is circumscribed, homogeneous lesion, so it's a score of 2, PI-RADS 2. Since I can see the borders of the lesion, and it's homogeneous. Next, I need to go to the diffusion and ADC map. It is showing significant dark signal intensity on ADC, bright on diffusion, so I would score it either 4 or 5, depending on the size, cutoff value of 1.5, and it is enhancing in the perfusion. So the final scoring would be a PI-RADS 3. Previously, if we are using the V2 version, we would still call it a PI-RADS. We would call it a T2 score of 3, diffusion score of 4, and final score wouldn't change. So they took biopsy from this lesion. It was benign prostatic hyperplasia without PIN or malignancy. For this lesion, most of you were going with a PI-RADS. Check the PI-RADS. Most of you were going with a PI-RADS 5 lesion. Actually, it's a PI-RADS 3, which goes with the pathology, actually. It's just a PPH nodule. For this lesion, we can see clearly that there is significant dark signal intensity on ADC, bright signal intensity on diffusion, early focal early enhancement, and diffuse dark signal intensity on T2. And definitely the lesion is more than 1.5 centimeters, so it's a PI-RADS 5. Having a history of previous intravesicular PCG would raise the possibility or the diagnosis of granulomatous prostatitis, which is considered a great mimicker for prostate cancer. It can invade the seminal vesicle, it can invade the bladder base, it can look very aggressive on imaging. You cannot differentiate it from prostate cancer by imaging. The only hint is by having a previous history of intravesicular PCG injection. For this lesion, most of you got it right, with 91% got this as PI-RADS 5 lesion, and 74% of you got it right as granulomatous prostatitis. 16% were going with prostate cancer. You would be completely right if I didn't provide the history of PCG injection. For this lesion, clearly you can see that this is a peripheral zone nodule. If we go to the ADC, it looks intensely dark on ADC. There is no definite abnormality on diffusion. And it has a focal early enhancement. So if we would score it from only these images, it looks as dark ADC, no diffusion signal. So it's a PI-RADS score of 3, early focal enhancement. You would think that it's a PI-RADS, you want to upgrade it to a PI-RADS 4. But if you go to the sagittal images, you can clearly see that the nodule has a capsule at the area of the arrow. So this is typical for an extruded PPH nodule. So it is benign and it's a PI-RADS score of 2. Most of you got it right. 38% were going with PI-RADS 2 nodule. It's an extruded PPH nodule. 29% was going with a PI-RADS 3. 31 was going with a PI-RADS 4 lesion. Again, this is a common pitfall. Always assess your sagittal and coronal images. Look if the nodule has any capsule or not. Presence of a capsule goes with extruded PPH or confirms that it's a PPH, which was confirmed by biopsy. What is your PI-RADS? This lesion, it's a PI-RADS score of 1. The typical location, posterior midline, goes with posterior midline pseudo lesion, where the peripheral zone, where the peripheral capsule joins or fuse in the midline, which may fool you into PI-RADing this lesion as a PI-RADS 4 lesion. It's dark on T2, dark on ADC map, bright on diffusion, and it shows enhancement. The only hint is in the location. It's midline, posterior. Always look for the coronal and sagittal images to look for any discrete nodule that has focal bulge or extracapsular extension. Then you would raise the possibility of prostate cancer and give it as a PI-RADS 4. So just to summarize, this is the major changes on the transitional zone was on the score 2. If you have a score 2 lesion, then assess the diffusion. 3 or less, it stays a PI-RADS 2. 4 or 5, then you have to upgrade to 3. The peripheral zone, only the changes were for score of 2. They added or emphasized on the morphology, having linear wedge shape, abnormal signal intensity goes with the PI-RADS 2. And they added the definition of having, or they allowed the lesion to have a marked dark signal intensity on ADC or bright on diffusion, but not both. And still you can call it a PI-RADS 3. Take home points. The PI-RADS system is aimed to improve detection, localization, and characterization of a clinically significant prostate cancer. Most notable changes affected the transitional zone, previously scored as a T2. score 2 of 2 and a diffusion score of 4 or 5, which will now be elevated to be a PI-RADS category 2, from category 2 to 3. The diffusion lesion with linear or wedge shape morphology are scored as a PI-RADS 2. Always be careful before saying that the lesion is linear or wedge shape. Always assess your sagittal and coronal images. Look for focal bulge or discrete nodule before saying that it's linear or wedge shape, not to miss clinically significant prostate cancer. And finally, the PI-RADS continue to be an evolving system with its goal to reduce inter-reader variability, ultimately improve the patient outcome. These are my references, and thank you. Any questions regarding the cases?
Thank you Hana, يعطيك العافية. Excellent presentation. أنا ودي بس أرحب would like to welcome all colleagues who entered during the lecture. حياكم الله جميعا كلهم باسمه. If anybody has